if you explain these things to the patients, as what I often tell the patient is, look, the cancer that we started treating you with way back when, with androgen deprivation therapy and perhaps docetaxel, now after AR inhibition, the tumor's evolved.
Exactly.
The tumor is now a different tumor. We saw the Stand Up to Cancer Dream Team biopsies from UCSF showing that a good 20% are neuroendocrine. And there's no particular clinical feature that predicts for neuroendocrine. So do you have a trigger point for when you're going to use, for example, Cabazitaxel? Let's talk briefly about that evolution. How early are you using Cabazitaxel?
So I'm looking at the CARD trial. I think that's the way I've based my practice in the past. So the CARD trial is a study that looked at sequential treatments in castrate-resistant disease. So generally we would use a next generation antiandrogen like abiraterone or enzalutamide first, then go on to docetaxel. And the question has always been with our patients, what's the next step, which is right. A lot of people would try another next generation agent, so Abi versus Enza, Enza versus Abi, or of course go on to chemotherapy. And the thought was, well, chemotherapy is more toxic, we don't want to use it in this situation. But the CARD trial helps answer that particular question. So it actually was a very clinically relevant study. Patients who had received either Abi or Enza, then docetaxel, they received the opposite antiandrogen in a randomized fashion, and it was compared to Cabazitaxel. And lo and behold, Cabazitaxel had a better radiographic progression-free survival, overall survival, better PSA decline rate, and also better objective response rate. Yeah. So it seems that Cabazitaxel is a superior drug in this particular situation to enzalutamide.
And lending a lot of credence to the idea that the tumor has evolved away from androgen receptor dependence into this more neuroendocrine, more chemoresponsive. Have you identified or maybe potentially used the idea that if you have a BRCA or one of the driver mutations, are you thinking that these should be given chemotherapy earlier?
Yes.
Okay.
Yes.
Yeah, I've always wondered about that because my limited experience with BRCA is that they can get long responses to androgen inhibition, but sometimes they're very short.
Yeah.
And then you're going, okay, I need to treat these guys, and chemotherapy is right there for you.
Exactly, and this is, I think, one of the key points about DNA repair. And one of the things that we never really, I guess, one of the surprises I had over the last couple of years is that when you administer drugs such as abiraterone, and you look at the DNA repair enzymes, there's a downregulation. And the same thing with androgen blockade. So I could never really rationalize why we were giving radiation therapy plus hormone therapy together. Couldn't understand the mechanism for that. And now it makes complete sense. By giving combined radiation therapy, hormone therapy for localized disease, you're downregulating some DNA repair enzymes, you're making the tumor more sensitive to radiation therapy, and there's your mechanism. So I think we're understanding more about the biology, not only of late-stage disease, but early-stage disease by these particular agents.
So going back to the CARD trial, is this practice changing?
Absolutely, yes.
Okay. So in a patient, in say, for example, the patient you and I talked about hypothetically, you've given them, say, docetaxel up front for metastatic or abiraterone up front for metastatic along with LHRH agonist, you're then moving into a resistant, an AR independent, and you're going to do CYP-T, and then you're going to not do second generation enzalutamide, or are you? Do you use the duration?
Yeah, the duration, I think this is something that the CARD trial did not account for. So one of the things I think we've all seen anecdotally, if you respond for a long period of time to an initial next generation antiandrogen, you have a lot more likely chance of responding to the second one if it's a long duration. I've had some patients who I've treated with multiple hormone treatments. I had one patient recently who had been on ketoconazole and hydrocortisone for almost 7 years, and then we put him on abiraterone prednisone for another 3, and then he got some mileage out of enzalutamide afterwards. So biologically, what's different about this patient?
Right, suggesting that it's addicted to the androgen receptor.
Exactly.
So there is something about some of these tumors where they stay androgen sensitive, or at least somewhat androgen sensitive.
Exactly.
So the difference in the CARD trial was that they were required to be independent of androgens as based on lack of or short duration, but not necessarily short duration response to androgen inhibition.
Exactly.
So yeah, it's a challenge, isn't it, to know what to do?
It is, but again, you've got to tailor to your patient. You know, the other issue too, of course, that I think is very, very important is should you be adding carboplatin to Cabazitaxel based upon the MD Anderson data? I tend to do that in a patient who may have liver or visceral disease. And the Anderson data is very, very exciting. It's being confirmed in a larger randomized trial right now. But that's also another avenue. Carboplatin or the platinums have been always there, and they've always had a level of activity. I think we don't necessarily think about those up front, but these are something we have to think about.
I had a funny anecdote from one of my friends who was trying to get Cabazitaxel, got it approved. He wanted to add carboplatin, and when he told them that he was going to give carboplatin and Cabazitaxel, they said, "We're not paying for either one." He said, "But wait a minute, carboplatin is cheap, and we'll be happy to eat that cost." They said, "Nope, you can't give the combination."
I've had something similar where patients have had the Cabazitaxel approved, but the carboplatin disapproved for $300. They said, "Fine, we'll pay for it."
Right.
But no, that's actually very, very interesting. You know, it's unfortunate that the drug satroplatin that we used a number of years ago, that we didn't understand the DNA repair pathways. Because I think that trial that Cora, Oliver, and I did would have been a positive study.
Yep.
Had that
because we all saw those small number of patients who had dramatic responses.
Exactly.
And the FDA's look at it was that it didn't have enough power to show a survival advantage, even though there was a tail.
Yes.
You know, I mean, we probably missed an opportunity there.
Absolutely. I actually tried to recently get that drug for a patient. You can't get it anymore.
Can't get it.
No,
it's not available.
Yeah.
That's disappointing. But it's sad to think that the insurance companies are not letting us use carboplatin, which is well established, and it's very sporadic.
Yeah.
Do you notice that? I mean,
yeah, exactly.
It's like one company will say we'll let you use carbo, and the others will say no, you can't.
I had a patient who unfortunately this patient passed away, but he had a CHEK2 mutation, and he unfortunately could not qualify for any of the PARP inhibitor trials because of his platelet counts. He actually sued his insurance company, lost.
He lost.
And unfortunately, he passed away 2 weeks after that event. But this again is showing us we've got so much information, and how do we use that, and how do we convince the people that are paying that this is useful? And the rapidity of the knowledge is logarithmic. Unfortunately, everything else is lagging behind in getting these to our patients.
Yeah, certainly the insurance companies and third-party payers are not necessarily understanding what we are learning. The faster we learn, the harder it is for the insurance companies to keep up.
So perhaps we need, as academicians, to educate them and help them understand, because our patients really deserve this.